Hey, welcome to EMS Office Hours. This is Jim Hoffman. These are your Monday Minutes. Guys, this is in fact the last Monday Minutes for the Quick Study Help Tips Quick Study Guide. It's been a long journey, guys, and I'm so glad you're here to watch the last episode. Now, it won't be the last episode for the Monday Minutes. We will continue with Monday Minutes, but it won't be a structured sort of thing where it's one topic after another, sort of a video review guide. It's going to be on things that pop up in the media, things that are trending, stuff like that. So we're going to, of course, keep on with the Monday Minutes. It just won't be the quick study help tips, okay? But, of course, go to the quick study help tips on YouTube or here on the blog at emsofficehours.com, and you can watch all of the quick study help videos from the very, very beginning to the end. And I will go ahead and do a quick post on that shortly so you can get an actual link to go right to that content. So, finishing it up, guys, on Extremity Trauma. And, this stuff isn't mind-blowing, right? So we're going to kind of finish up on that. Of course, I always encourage you, go check out TurboMedic, guys. Get yourself a free membership there. I call it an insider membership. And I'm the first one to have an insider membership for my members where they can get gigabytes of digital content and hours of audio and video, a few practice exams at the free level there, and of course exclusive access to the Facebook group for TurboMedic. So go check it out, guys. It's at emsco.com/insider. Now, of course, I always try to stress why this stuff is important. It doesn't matter if this is the last video in this series. It doesn't matter if it's going to be an ongoing key topic that I cover in the future or ones that I've done in the past. The reason this stuff is important, guys, is that this is not designed just to get you to memorize stuff for an exam. I want this to help build your knowledge base, to encourage you to look further, to master these topics, okay? And I want it to be a tool to help you make better clinical decisions, write better reports, and interact more effectively with other healthcare professionals. So, guys, let's get into it today, guys. Talk about extremity trauma. I just want to review. I talked last time the major reasons why we get this, right? Assaults and falls and car accidents, board injuries, okay? Rarely are they life-threatening. Of course, the exceptions to that would be femur, pelvic type injuries, or even potential limb threats, okay, where you have an issue with the injured extremity where there is a circulation or nerve issue happening, or a neurological issue happening, okay? So, but today I want to talk about the assessment and the treatment goals. Now, the DCAD PTLS kind of acronym I put here goes for all trauma, but it really can use this when you talk about extremities, right? Things you should be looking for quickly, right? In a rapid assessment, your rapid trauma assessment, right? Deformities, confusions, abrasions, punctures, penetrations, burns, tenderness, swelling, lacerations, all this stuff you want to look for, okay? And that's going to help you decide what your treatment and what your goals can be, right? Because sometimes we can't do certain things if a patient is experiencing certain elements, okay? So, again, just to go over real quick, guys, your deformity, looking for that pain, that tenderness, that swelling, bruising, do you have exposed bone, okay? Bleeding, is the bleeding external or internal? Of course, external bleeding is pretty obvious, but the internal bleeding, when you see a lot of that swelling, could be from blood, right? It could be ecchymosis, that the bruising, it could be a hematoma, whatever it is. So keep that stuff in mind, that the bleeding could also be internal. So, observe that extremity and the injury that might be going on there. Now, quickly, guys, there's not much we're going to do, right? We have our treatment goals, right? What we can do to manage, all right? Of course, we're going to control that bleeding. Direct pressure, pressure points, elevate the extremity, a tourniquet if need be, even cold packs, right? Especially you have closed injuries, cold packs to help maybe stop the bleeding going on internally. That's the localized area. And we're going to treat for shock, guys. Always keep that in the front of your mind, okay? Um, and we want to prevent further injury. Keep the limb in its anatomical position if we can. Move it into the anatomical position if it's dislocated, right? Splint it. Check for your neurological, your pulses, your motor, your sensory before and after splinting. And of course, you want to follow local guidelines, guys, on what you are allowed to do, because you don't want to be adjusting a limb to an anatomical position if your guideline doesn't allow that. But most guidelines and most textbooks will tell you that if it's not extremely painful and you can do that, to go ahead and do that, because sometimes you might have to do that to regain circulation or to regain neurological uh, intact, right? To move it so that they can't suddenly they have no circulation to the distal extremity, or they can't feel you touching. Sometimes moving it to the anatomical position will reestablish that circulation. Okay, so if you can do that, go ahead and do that. If not, you want to splint it, of course, in the position found, and you're gonna note how you found it, where you found it, if you moved it, the neurological before, after, and then keep assessing to ensure that the pulses, the motor, the sensory is not changing while you're taking them to the hospital. It's very important, right? The ongoing assessment. Okay, you get your initial when you splint it, but then you go into the hospital 15, 20 minutes down the road, reassess it. Okay, don't just splint it. Don't set it and forget it. Okay, we keep reassessing it. Now, the femur, guys, we mentioned this before, can be dangerous, blood loss, pelvic blood loss, right? But if you've got a fractured femur and you're considering using a traction splint, whether it's a Hare or a Sager, a lot of them have that issue where you cannot use those traction splints if you suspect also a pelvic fracture, a hip fracture, a knee fracture, a knee involvement, or also a severe injury to the foot or ankle. When you put that ankle hitch on, if the ankle's broken, you don't want to be yanking on it with the ankle hitch, right? So that might be the things that you're going to, of course, not be able to go ahead and treat that fractured femur with a traction splint. You will have to go ahead and mobilize it using other methods if the same side, the same limb is being affected, right? All right, so guys, this is real quick. This is basic BLS stuff, okay? On the ALS level, when you have patients with fractured femurs and pelvises and hips and things like that, open bones, things of that nature, a lot of times as a paramedic, you're going to give some sort of pain management to the patient as well, all right? You might even offer antibiotic therapy en route to the hospital. A lot of agencies now are allowing you to give IV antibiotics in the beginning if you have an open fracture, okay, to get that antibiotic on board. Of course, that's local guidelines, what you can and can't do, but that is another treatment modality that's being pushed out there that I think you're going to, if you're not seeing it now, you will start seeing it more and more. At the paramedic level, there's a few more things we can do beyond the BLS, stopping bleeding, and splinting and things like that, as far as pain management and the antibiotic therapy. Okay, so just some things to think about there, guys. Again, this is it. This is the last one, guys. Thank you so much for joining me. That is it. It's a nice, quick episode on finishing up the extremity trauma, right? Be sure, like I said, check out TurboMedic, become an insider member there. Again, that link, emsseo.com/insider. Guys, I hope you enjoyed these episodes. I hope you look forward to seeing you in the future episodes. Engage with me, guys. Meet me up on Facebook. on my first Facebook.com/EMS professional. Follow me on Twitter or on LinkedIn, Instagram. I'm at EMS Safe on both of those channels. I'm also on LinkedIn. You can look me up there, Jim Hoffman, there on LinkedIn as well, if you prefer that channel also. Love to connect with you guys and kind of get a little bit of different content out to you on each of those channels. All right, so guys, that's it. If you have minutes of your own, you want to see something covered that I have not covered, something that's trending or something you're looking for help on, you'll go ahead and contact me. It's contact@emsofficehours.com. And go to emsofficehours.com. If you're watching this on YouTube, go there, check out all your episodes there, check out the podcast there, and other content that's on the blog there as well. Okay, and I do have some content coming up, just so you know. I'm trying to work on a few sort of scenario-based stuff for the sample OPQRS assessment techniques to kind of give you a feel on how you would do that for different types of patients. I did get a request for that, and I'm going to go ahead and start doing 1 or 2 videos on some scenarios for that to kind of give you a feel on different patients and how you would approach using those techniques in order to get that information to help you with your assessment, your treatment, and your transport. Okay? All right, guys, that's it for me. As always, I'm Jim Hoffman for EMS Office Hours in the Monday Minutes. Stay safe.